This is one of the famous topics that they ask in FMG exams, or rather they used to ask, but students would always get confused in it. Let's make it simple now. There is a man with history of peptic ulcer who has had a surgery, truncal vagotomy, Billroth 2 reconstruction. Alright. And post-operatively, he is getting some complaints. Postprandial weakness, sweating, lightheadedness, pain, diarrhea. So what surgery has he had? Peptic ulcer surgery, Billroth 2. Billroth 2 means he's had a gastrojejunal anastomosis. So the stomach is joined to the jejunum after doing truncal vagotomy and antrectomy. And post-operatively is having some problem postprandially. What problem is this? Of course, you should know this. This is called as dumping. This happens after certain gastric surgeries where the food from the stomach quickly gets dumped into the jejunum. Here there is a GJ. So whatever he eats from the stomach will quickly go into the jejunum. And it produces some problems, some symptoms. Those symptoms are called as symptoms of dumping. Now, what are they asking you? Best initial management. Now understand why dumping happens, then you will get the answer. Dumping happens for two reasons, or it is of two types. One dumping is called early dumping. Early means this will manifest usually within few minutes after meals, usually within few minutes, where if the person has had certain foods which have a lot of osmolarity, osmotic foods like Coca-Cola, milkshake, what they will do when they reach the jejunum, they will suck the fluid from the plasma to dilute it. So they will suck the plasma volume, and because of that, the person gets hypotension. It is because of plasma volume reduction. So plasma fluid goes into the jejunum to dilute it. So he gets symptoms of hypotension, like he will be lightheaded, he may be drowsy, he may be dizzy, he may have a syncope. It's all because of hypotension. The other type of dumping is the late dumping. This will usually manifest 1 to 3 hours after meals. This happens if he consumes foods which have a lot of glycemic control or a lot of glycemic index like bananas, maida or refined flour. So when it will reach the jejunum, those sugars, simple sugars, will quickly get absorbed. They will cause an insulin spike, and that insulin spike will cause a rebound hypoglycemia. So late dumping is because of rebound hypoglycemia, in which the person gets symptoms of hypoglycemia like tremors, palpitations, sympathetic overactivity, all those symptoms, neuroglycopenic symptoms. So these are the two types of dumping. The first line of management will always be avoid the dietary triggers. If he avoids the triggers, the dumping will be controlled. Usually it is a self-limiting condition. If he avoids those dietary triggers like Coca-Cola or maida, then the dumping will be controlled, right? So best initial management is going to be dietary advice, counseling that the symptoms will probably abate within a few months of surgery. So this will be the first management, right? They asked you the first management. If this doesn't work, dietary management doesn't work, then there are some medicines you can be given like acarbose, which is a glucosidase inhibitor. It will not let the complex carbs get converted to simple carbs. So you can get acarbose, you can get somatostatin analogs like octreotide. They will reduce the insulin response. And if it doesn't work, if nothing works, he may require a surgical correction. The surgery may have to be reversed. So Billroth 2, whatever anastomosis was done, may have to be undone. Right?